covered. We can come back there later. Okay, here is your scenario. Is everyone familiar with this scenario? Those that are less internal medicine or neurology, any question on this scenario? It's very basic, but
so what's up with the question?
let's see what.
So I read them.
So the patient comes with this history, right?
Yeah.
He's a about 70-year-old, and how you would call this here? Is a TIA or is a stroke?
TIA.
How can you tell?
Result.
Is result. Good.
Half an hour.
Half an hour, and is over. The moment you see the patient, he tells you that had symptoms for half an hour. Good. So it's a TIA.
And we want to score him, ABC score.
Yes.
So he's,
And I think that he is here, or
blood pressure is high. So ABCD score is high. You need to CT.
so can you help maybe the one that are not in internal medicine or neurology? What's the ABC score? Roughly, you don't need to be precise.
We use this score to see if the patient with TIA or stroke the TIA needs to do a CT or not. So the cutoff is 2. More than 2, we do the CT scan. It's based on age, diabetes, blood pressure, and diabetes, age, blood pressure, and the disability.
Yeah.
The
And-
disability.
So it's a sort of prognostic score that help you guessing the severity of the event and the likelihood to find a lesion. And the reason to do a CT is finding a lesion that may then drive a different treatment. So in this case, the score is 2. You would go for a CT or not here? Yeah, okay. Physical exam is here. And now, problem is a diagnostic problem here?
It's a therapy problem.
Is a therapy problem. Why is not a diagnostic problem?
Because we are not as questioning the CT now, the examination, examining the intervention. What we do for this.
Right, but what I'm saying is, do we have doubt that this is a TIA? No, this is a TIA. Is TIA always evident? No, that's why sometimes we do the CT. Can be confused with what? Seizure sometimes, but here clearly there are not any component of seizure. Migraine,
Masses.
yes, masses, but usually, again, you can have a appearance, disappearance of symptom, but it's not common. In general, we would say this is a clinical picture. Is enough to decide that we can move to treatment. Now, what's the question here? Yes. How you would frame this question here?
Adult male came with the TIA, CVA.
Okay. Anything of what we saw in the history or in the physical exam is relevant to the PICO? Blood pressure. Why you think that's relevant?
It's a risk factor
For what?
for having the TIA.
Is a risk factor for having a TIA. Okay, but we have said that he has a TIA, so we are not in the diagnostic setting. I'm trying to help you focusing. We said that we are in the treatment. So
Managing the blood pressure after the TIA could be a question here.
High blood pressure is the risk factor to have a rupture vessel and atherosclerotic vessels.
okay, and so
So blood pressure should be done.
Yes, but if you have a ruptured blood vessel,
Yeah.
what you have?
Hemorrhage.
Hemorrhage. Which, what's a TIA instead?
It's not
It's ischemic. It's not hemorrhagic.
Hemorrhagic transformation.
I mean, you may imagine a very small hemorrhage that gives you symptom and then disappear. Do you think that can be 30 minutes? It's very, very unlikely. But if he is right, and high blood pressure can facilitate, I'm not sure if he's right, but what he's saying is that high blood pressure can increase the chance of having a broken vessel. Can this have any connection with treatment? We are,
That is antiplatelets on this patient.
so what can happen?
Worse
We might
than
have
hemorrhage.
Worsen. So, okay, you would treat differently patient with and without hypertension. Right, if that's the case, you want that component in the PICO question. Even if the question is about treatment, if a characteristic of the patient change your treatment,
Hypertensive patients.
yeah, then you want it in the PICO question. So the PICO question, let's start filling it. So patient with a TIA, male, do you think it's important to put male there?
Yes.
Why?
Isn't there differences in treatment?
Okay. Are you aware of any stroke prevention medication that works
Difference between male and female.
What's happening? In male or females? There was an old story of aspirin having a different effect in genders. Is not, as far as I know, has been abandoned, but ideally there was some suggestion that that was the case. So let's put male there. What's the intervention?
Giving Plavix.
Plavix. Now, there's a note there that says you use your background. Would you give aspirin to this patient?
Yeah,
Yeah.
there is evidence for it. But he was not on aspirin before that.
Oh, good question. So, why that's a good question? It's not a question, it's an observation. But anyways, why is important what he noted? He was not on aspirin.
To check if there was any contraindication to give aspirin.
For example,
He's drug naive or not. He's drug naive or not. He's on antiplatelets or not.
Right.
This is failure of aspirin or not.
Failure of aspirin. Because if you are on aspirin and you have a TIA, you would think that aspirin is not enough. If yourself, you have a TIA while taking aspirin, the day after, you don't believe anymore that that aspirin will prevent TIA for you. You had one yesterday and you were taking aspirin. You need something more. But this patient was not on aspirin. Now, we don't need to do a search for deciding if giving aspirin or not to a patient with a TIA. Everyone with a TIA gets aspirin unless he gets another TIA and then something may happen. But if I were to ask you, he was not on aspirin. This is the first ever TIA for this patient. When you start aspirin?
I am. After the CT, I have normal CT.
After the CT. Why after the CT?
To hemorrhage.
Because you want to rule out an hemorrhage. Okay. So
Having aspirin.
the patient comes in, does the CT, there is no hemorrhage on the CT. Is the CT reliable to say no aspirin, no hemorrhage?
Yes.
In the beginning, yes.
Yeah, okay. While for stroke, it may show it or not. You may need to repeat. But for hemorrhage, you see negative. That's the radiologist here. So you see negative and you are sure. So you start aspirin immediately. Okay. Is that enough?
For intervention.
Or initiation of aspirin.
No. As a treatment. Is that the only thing you can do? How would you expect someone...
He's a TIA patient.
Yeah, a TIA patient. What's the chance for a TIA patient to have another TIA or a stroke in the first week after the TIA?
Around
It's very high.
20 to 30%.
Yes, it's very high. And
We control the risk factors.
right. So we usually give a statin, we decrease the blood pressure, and so on. But the risk in the first week is very high.
Yeah.
So why don't we give him something more? Why don't we give him
Anticoagulation.
anticoagulants? Or,
Showed no evidence.
I mean, what you do after a coronary syndrome, a NSTEMI, or STEMI and PCI, what you give the patient?
Give anticoagulation.
Double antiplatelet. And why you give double antiplatelet and not only aspirin?
Because show evidence. Benefits.
There is evidence of benefit. So there is less incidence of reocclusion. Why not for stroke?
It was there. As Brendan, I think they did one study for that dual antiplatelets. And this is the study. I think.
This is the study, yes.
It's in China, I think.
Is in China. But do you usually do double antiplatelets
Actually, in
for
our
stroke?
country, still not yet. The neurology, they don't go for it.
And maybe they are right. That's what we will be discussing today. But the background is there. For myocardial infarction, we do. Stroke is more or less the same.
Same.
There is one difference.
The size.
No. How often you bleed in the heart? Never. So there are no side effect in terms of bleeding at the coronary level. You can only do better. If patient on double antiplatelet for myocardial infarction bleed, where they bleed?
GI.
GI or brain. They don't bleed in the heart. So the cardiologist, is there any cardiologist here? They look just at the heart. They don't care about you bleeding in the stomach or you bleeding in the brain. If someone bleeds in the brain, then it's the neurologist that take over, or GI. So they just push it. They were going for 3 antiplatelets at some point because, of course, the patient doesn't come back.
Yeah.
But he may go back to someone else. So for stroke, it would be back to you. So you consider, but you don't know. So let's say that that's our question. We want to know if clopidogrel, what do you think you will be looking for? Clopidogrel versus placebo or clopidogrel versus aspirin?
Ethically versus aspirin.
Why would you take away aspirin?
Ethically, it's better to compare it to placebo, but for aspirin, ethically, it's better because I will not prevent well-established evidence.
What about searching literature for clopidogrel added to aspirin? Why not? That's what cardiologists do. They do aspirin and clopidogrel.
Versus aspirin.
Versus aspirin, yes. And what's your outcome?
Rate stroke,
Oh, that's there, but then what else are you interested in?
mortality,
Mortality?
rate of bleeding.
Bleeding.
Yeah.
Okay, so bleeding, mortality, and stroke. Okay, so that's the question.
Can we separate as the outcomes as primary and secondary outcome, or
Yes, you can.
mortality is the primary outcome and the rest is secondary outcome? Or combined now?
So, who has any suggestion? How would you like the outcome to be grouped? Primary and secondary is good. Can you imagine of another way of grouping abstract outcome?
Combined.
Combine. What do you mean by combine?
All the outcome is primary outcome.
All primary. Okay. But still, to make up your mind, can you think of 2 categories, not primary and secondary?
Okay.
There are
Mortality.
short-term and long-term, okay. But in general, how, in a case like this,
Benefits and harm.
benefits and harm. What's benefits here?
Less stroke.
Reduction of stroke. And what's the harm?
Hemorrhage.
Mortality
Hemorrhage.
is neutral, is not a benefit. Mortality is always there. You impact mortality by reducing stroke. and you increase mortality by causing hemorrhage. So mortality, you never call it benefit or harm. Mortality and survival, they are sort of composite. Is what counts in the end. But taking mortality away, the others are usually either beneficial or I find that more useful than primary and secondary, because primary and secondary may change, and what is primary for me may be secondary for you, depending our specialty, the patient sometimes values things differently. But we usually agree on what is a benefit and what is a harm, and we need to balance them. So it's good to always have one benefit and one harm in, so that you don't forget that each treatment has some side effect and you measure them. Then if you call them primary or secondary, it's okay. And the other suggestion is never have more than 7 outcomes. It's like trying to play with balls. 3 is already complicated, 7 is impossible, unless you are able to play them different ways. Okay, good. So are you happy with the PICO? This is just an exercise because we know what we have found, but in general, would you agree with the PICO? May I ask you about the diagnosis? This is not diagnosis, you will have it, but we have a radiologist, and we said no need for diagnosis. Do you usually think when you order a test, and a test can be a CT scan or can be a CBC, how your decision will change depending on the result? So in this case, we ask a CT. If you tell us no bleeding, we go and give antiplatelets. If you tell us bleeding, we don't give antiplatelets. If you tell us I don't know, we get pretty upset.
Yeah.
So we don't like non-diagnostic images. You have to decide. We request you do, and you come back with positive or negative.
Yeah.
Because if you start in 50% of cases saying I don't know, we stop asking, and you run out of business. Because it doesn't help me. If you say I don't know, then I have to do something else. And the same is for lab tests. So you should always do that way. When you order a test, if the result doesn't change what you do, don't order it. He might not be happy, or he might be happy, depending if he's on a salary, if he's paid by the hour or by the test. If he's paid by the test, he wants test. If he's paid by the hour, he doesn't want test. So that's depend on the system. But in general, if you don't see the value of the result, if it doesn't change what you do, don't ask that test. No point. But here was not a problem. Okay, so we get this study. Now, the question that one should never, okay, they build the search strategy, and they found 2 studies, the Plato study and the Wong study. And the one you have been given is the Wong study. Now, I shouldn't ask you if you have read the study, but if I were to ask you, you would answer, yes, we read the study, we liked it a lot. Right? You liked it a lot, all of you. Now, that was not the question. We don't care if you liked the study or not. We are very thankful that you read it. If you didn't, you'll do it now. And you answer all the questions in the chapter. If you are good and you participate to the discussion, we go on this way. If not, we go around the table, each one answer one question. So answer the one you know. If not, we go around the table. Who starts? Any question to where we are now? So, do you want, say, 5-10 minutes to refresh yourself with the study?
We go one by one?
Yeah, no, I was asking if you need to look at the study again. Or is there anyone who really read the study yesterday and can tell what the study was? No, no worries. I mean, we are in between friends. This is not, this might be recorded, I don't know. So, when you read a study, do you need, where you start?
Let's talk about that, sorry.
Abstract, that's good. And then
I go to the
Methods.
methods. And you read what you need, you don't read everything. The statistical analysis you may not want to read, depends. But at least you read what? Two things in the methods.
Type of study.
Type of study,
Randomized.
oh,
The type of
yes,
study.
but first of all, you have a patient.
Is it relevant to the study itself, the design of the study? Is it relevant to what I'm doing or not?
Okay, but that's fine. Let's assume that it is a double-blind RCT, perfectly done. Still may not be relevant for you. What makes a study relevant to you?
Sample size.
No.
If it's significant or not? If it's statistically significant?
You are already one step ahead. You have checked something else before.
The quality of study?
No? Step back. Before knowing if the study is good or not, you need to... Sorry?
The background of the study?
Not the background? If you were to enroll a patient in a study, what would you need to know?
They are equal?
No. You have
Characteristic.
the characteristics of?
Inclusions?
Inclusion criteria. The inclusion criteria, I don't know if you do studies in your setting, but if you are the local PI or you are involved in a study and they tell you you are rotating in neurology and they tell you we have a study, we are testing if clopidogrel is better or not for stroke prevention. If you see a patient, a male patient with or without hypertension getting to the hospital within 24 hours from an event, not previously on aspirin, that's the kind of patient we are searching. These are the inclusion criteria. So the first thing to check are the inclusion criteria of the study. Because if the patient you are caring for or the patient population you are trying to come up with a treatment for doesn't fit the inclusion criteria of the study, that study can be the most perfect study ever, the proper design, the right p-value, all the rest, but doesn't matter to you. So to be applicable to a patient, for a study result to be applicable to a patient, that patient should have been enrolled in the study. So if the patient characteristics do not match the inclusion criteria, could be the best ever study, doesn't apply to that patient. So the first thing you read are the patient characteristics. Sometimes they report the inclusion criteria, sometimes they just report the patient characteristics. You save ton of time, you start there. If the patient characteristics are not the one for your case, okay, next, and you go to the following study. So in this case, are the patient characteristics
Mix with it.
matching our case or not?
Yeah.
Yes.
Yes,
Exactly,
good.
yeah. Smart, yes.
And that's the first thing you check. The second thing you check in the outcome, I told you, in the methods, is the outcome.
Yes.
If you are interested in stroke prevention and in, we said, bleeding, you have to check, is this study reporting on stroke prevention and bleeding? Because the study might report about release of prostacyclin in the brain.
Liver.
Very good. She might be very happy and she might set up a new diagnostic based on, I don't know what you can mark in prostacyclin and get a beautiful image of the brain where prostacyclin is released, but that's not what we are looking for today. So when one tells you read methods, I know that you don't say, but internally, I don't like to read methods, it's so boring and complicated and I don't understand the stats. That's not what you have to read in method. You have to read patient and outcome and get the judgment that that study applies to your patient. Then, if that's the case, you move to check what he was saying. Is randomized, is double-blind, is concealed, is powered enough, got a statistical significant result, fine. But that comes after. Okay, so do we proceed with this study?
Yeah.
Okay, so is appropriate for us. Are the results valid? What does it mean, are the results valid?
Valid in our scenario.
Yes, and we have assessed that, but now we say, okay, our patient could have gone into the study. For the study to answer the question, this is a question about treatment. So Fahd this morning told you about the possibility of a confounder. And the solution, someone of you told that the solution for confounding is randomization. Because randomization does what? Spread the characteristic of the patient the same way in the two groups. Is that automatic?
No.
No. Can happen or not. Usually it does happen, but sometimes it does not. How can you check if a randomized study was using a successful randomization?
Table 1.
Table 1, the famous table 1 that every randomized study has. What's table 1? He knows what table 1 is. Let's see if someone else knows. What's table 1?
Characteristics of participants.
Yes, and how usually table 1 has the characteristics on the rows, and what are the two columns?
Assigned to placebo.
Yes, assigned to placebo and assigned to active treatment. So the treatment group and the control group. Do you expect p-values on the treatment on table 1? No. Unless it's a New England Journal of Medicine paper, because New England continues to ask for p-values there. And of course, you put them there. If they say you will publish, but you put the p-value, that's no problem. It's very easy to calculate the p-value. But what that p-value means? Yeah, I mean, it says there are more male than females in the treated group. So what? I mean, it means something, but what does it mean? Would you expect differences?
No.
No. So if there is a difference, and that difference is not by chance, the concept of p-value is the difference is not by chance, means that something went wrong in the randomization. You would not expect a difference. So, but the difference doesn't necessarily need to be significant, statistically significant, to be important. If you have 100 patients and you end in seeing that all women end in one side and all male on the other side, there's something wrong anyways, even if it's not significant. There was something wrong with the randomization. So if the P is there, you can look at it, but you don't really care. What you care is you expect to see the same number on the two columns. Where do you think is more likely for this to happen, small study or large study?
And a difference between them? Or
Not to have a difference.
not to have, with big difference, with big.
Big.
Yeah.
The larger the study,
The better the randomization.
yeah, randomization works, but it's like tossing a coin, right? You would expect 5 head and 5 crosses. Usually you get 6 and 4. You may get 3 and 7. But if you toss the coin 1,000 times, you end in being 490 to 510. There's not so much variability. The variability is always about 10 in tossing coins. So you can even get 10 heads or 10 crosses. If you throw 10, you can get 10. So it means all. If you throw 1,000, it's still 10 the difference, which is non-significant when you are at 1,000. So the larger the study, the better. Do you have any rule of thumb for the number of events in a study? How many events? Because what is true for random differences is also true for events. Do you have any idea of a safe number of events to observe in a trial? 100. If you have less than, not patient, events, if 50% of patients have an event, 200 patients is enough. You have 100 events. But if the events is 1 in 1,000, you may need tens of thousands of patients because you may have a trial of 40,000 patients, 4 events. 1 in one group, 3 in the other. Well, yes, is a 75 reduction, but it's 4 events. So the chance for that, instead that 1 in 3 being 2 and 2, you can guess is very high. So if you don't have a large number of events, you are not confident that that study can be reproduced. How many events in this study?
5,000.
No, those are patients. How many stroke or TIA?
Around 1,000 in 2 groups. In the 2 groups, 1,000.
Okay, so quite a lot. I think is a bit less.
Ischemic stroke.
Yeah.
500 in the aspirin group, 517, and 516 in the ischemic stroke.
Yeah.
And the clopidogrel plus aspirin.
Okay, so this is quite a robust study.
Please, can you tell us what the number of events is written in the method or
Usually it's the beginning of the result session or table 2. I should have a copy of the paper.
No, this is only stroke. Yeah, it's
Is in table 2? Okay.
200 in aspirin.
So let me see. Yes. So 300 event in the aspirin and 212 in the clopidogrel. And it's 11% against 8%. But you could have that 11, we'll see this afternoon by looking at a few study characteristics. If you don't have large number of events, the variability is unpredictable. Okay, now are we happy with table 1?
Yeah. Patient randomized. Yes.
And I don't recall anything wrong. This is okay, there's no p-value, so this was before. When is this? 2013, no? Good.
But it's always the same.
Yeah.
Yeah. It's randomized.
Okay, did the 2 group retain similar prognosis after the study has started? What is the most common thing that can happen during a study that makes the 2 group identical in the beginning but then become different?
Dropouts or mortality.
Why dropouts and mortality should be different in the 2 arms?
It will change the number of.
For example, because the treatment is difficult to take and patient gets bored or they have side effects or they die because one treatment is more effective, but usually mortality is an outcome, so doesn't count. I mean, is counted as an outcome, so doesn't affect prognosis. Is treatment. So,
Beneficial
no, it's other treatment. So say the antihypertensive treatment. This study is about clopidogrel and aspirin. Say that for some reason treatment of hypertension is left to the investigator. And then by chance, maybe that one group or one center, was this study done in one single center or many centers?
Many centers.
Many centers. So in some centers they might have been better at treating hypertension and in other less good. And for some reason, treatment of hypertension ends in being different in the 2 groups. And that may imbalance the study later on.
From where we can get this information? From where we can? From
usually there's a sort of table 1 down the road. So you have the patient characteristics at baseline and patient characteristics end of study. Why is not here? Because this is a short study. What's the time frame for this study? I think it was a month or something like that. 90 days.
90 days, yes.
So in 90 days, usually prognosis remains as it was. Okay, we move to any more on this question?
And well, the randomization was concealed.
So what's concealment of the randomization? What's the concept of concealed randomization?
As known as blinded.
So has something to do with blinding, but is not formally blinding. So can you tell me a method of randomization you know?
Computer or
Computer. So you get the next patient that would qualify for the study, and the study protocol tells you, you go on a website, you put in the patient initial or whatever it is, and you get a randomization. How you expect that randomization to be? In a study like this, what were the two treatments here?
aspirin and clopidogrel.
Aspirin, placebo versus.
Aspirin, clopidogrel.
Yeah.
Aspirin, clopidogrel, aspirin, placebo. Okay, so what would you expect the computer telling you back for?
It should be blind.
So what you get?
Group to group. This.
So
You can get the medicine or not.
right. So would be group A, group B,
Yeah.
right?
But we don't know what's group.
And then what you give to group A or B?
We don't know.
Yeah, you don't know, but what you do physically. You imagine I'm the investigator. I see the patient.
Are you even able to get from the pharmacy?
Give them code.
Yes. So what the pharmacy send me?
Code.
No, the pharmacy send me a box, and the box will say A or B, and what you expect to find inside.
The same thing.
Same. So the box A has a bottle with white pills, and it says A on the bottle. Take one every day. And B
Take one.
has B,
Yeah.
white pill, take one every day. I don't know what's in there. If I mix them up, we are screwed. There's no way of going back. You have to go to the chemist and ask to analyze the pill. There's no way of distinguishing them. And in this case, there are two bottles in each box. A has two bottles. One is aspirin and one is clopidogrel. B, one is placebo and one is aspirin. So I get from the computer A, and I give a box A. And then 3 patients after, I get again A, and I give a box A. Can be the same, can be different. I don't know. Usually it's the same. All A's are the same, all B's are the same. But some randomization, they mix them up. And the computer knows A number 93 was clopidogrel, A number 111 was instead placebo. So as a treater, I don't know what I'm giving. Does the patient know what is he getting? No. Good. So concealment means that the computer decides and it doesn't tell me. So that's concealment. If I don't have a computer, I may have A or B in an envelope, and the envelope has to be opaque. I can't go against the window and say, oh, that's an A. And this patient, I don't like this patient, he's not doing very well. I want this patient to be a B, because I think that B is the active treatment. So concealment means the moment I enroll the patient, I don't know what he will be getting.
It's concealed.
Yeah, that's concealment. While blinding, what is blinding? Blinding is I don't know what I'm giving the patient, and the patient doesn't know what is he getting. But that's after. Concealment is at the moment of randomization. I see the patient. This is next patient. I don't know if this patient will go to A or B until I decide the patient is in, and then I randomize. first you decide that that patient is good for the study, and then the computer or the list tells you this is A, this is B. You don't know what A and B is, that's blinding. You don't know if this patient will end in being A or B, that's concealment. I don't need to know in advance. If not, is there any surgeon here? No. If I'm a surgeon, I say, oh, I want to use technique A in this. Surgeons usually, they are not blind into what they do. They know, is laparoscopic or is open. But they will not know if the next patient will be one or the other before deciding if the patient gets enrolled.
So it's concealed.
Yeah. So first they decide this patient is good for the study, and then they are told what the treatment randomized to is. That's concealment. Okay. So that's our next question is about randomization and concealment.
Group were randomized.
That's a different question. So concealment is what we have discussed. Blinding is what we have discussed. Now, what does it mean? It's a very tricky question. So, what can happen? Can happen that I see the patient, I decide the patient go in the study, I ask the computer, I get A, and then for some reason that patient gets B, because pharmacy sent the wrong box, or because was randomized to A, and for some reason there were 3 patients that day gets the wrong box. Where do I analyze that patient? To group A or to group B? He was randomized to A, and then for some reason he got B. I count that patient in B or in A?
I count him in B.
No, I count him in A, because he was supposed to go to A. Then for some reason he got to B. Because if I was counting him to B, that would screw up the randomization, because that patient had characteristics, had unknown confounder that were balanced by randomization, and in the random process he was in group A. Then he got drug B, but that's a mistake. The patient belongs to group A. So I do the analysis in group A. And then you may tell me, but that doesn't make any sense.
Preserve the randomization, but won't I affect the results?
Okay, so you can do 2 analyses then. One is the intention to treat. This patient was meant to receive A. Let's see what happened to all those meant to receive A. Then say someone got B, but someone else never got to get the medication because he died before, or he withdrew consent to the study, or something happened, was a surgical study, in the wait time something happened and he didn't get there, or he got 1 pill and then he stopped. So you may say there's no way for clopidogrel to work if he didn't get the medication. It's not a matter of being A or B. He didn't get it, fine.
But there's an intention.
But you should still count them as the denominator of the group where they were randomized. And the reason is not just to make it difficult, is that the concept of randomization is to create 2 balanced groups. They are balanced if all the individuals are in. So my denominator has to be all those randomized to A, no matter if they took the medication, no matter if they took the right medication, no matter if they took it every day. Then you may say, okay, fine, I believe you. In real life, that's what would happen. There are patients not getting the medication, getting it wrong, and blah, blah, blah. But I want to know if the medication works in those who took the medication. You can do then a per protocol analysis, where you do the analysis only of those who took the medication. But the meaning of the per protocol analysis is that the medication works in patient who takes it. Works in patient who takes it. which is not the same as the medication works. So if you think of the patient taking the medication, you may say, having studied patient who took clopidogrel compared with patient who took aspirin, those taking clopidogrel did better. Okay, for the patient is an important information. If you come to me as a policymaker and you ask me, would you pay for clopidogrel? I would say, well, to pay or not for clopidogrel, I need to know if clopidogrel works, not for those who takes it, but for those who are supposed to take it. Because I'm not paying for the medication if half of the patient cannot take it because the pill is too big to be swallowed, or as a bad taste, or whatever is the reason why they don't take it. So you can do both analyses. You always, I mean, it's recommended to have the one where the patient were counted in the group they were randomized. What happened in this study? There is a sentence where they say that they analyzed the patient in the group where they were all analyses were based on the population of patients who underwent randomization. Is somewhere on page 14. Okay. Any question on this? What's the following question? And that's again table 1, right? Okay, then
with similar characteristics and risk factors? Yeah, it was, yeah.
we covered this already, right? Random and concealed, okay. Randomized, double blind, randomly assigned. You know what double dummy means?
Double blind, placebo control.
Yeah, double dummy means that there is a placebo, yes. And in this case, it's double because of the two medication. They use a computer-based system, so this is all okay. What are the relevant words here? Randomized, double blind, randomly assigned. Yeah.
This is all from abstract.
Yeah. It's a good abstract in this case.
Yeah, table 1.
Yes, that's table 1. Now, assignment to the group. So this question that we were discussing lately, were the patient analyzed in the group that they were assigned to? There's a sentence in the paper that is here on this slide. No patient withdrew between the time of randomization and administration of the first dose of study medication. All analyses were based on the population who underwent randomization, which means would make no sense to make concealment and then to allow that patient in one group drops. Would deviate the study from randomization.
Actually, it happened in one study. It was
And as a concept, as a basic concept, randomization, you told this morning, helps in balancing unknown confounders, right? Blinding and concealment, they help with what? With confounding? No, they help with bias, which is systematic deviation. I think that A is better, I take away bad patient from A. Or let's say it's a diagnostic study, stroke. The radiologist is involved in the study, he knows who's taking clopidogrel, And in those who take clopidogrel, it's kind of, yeah, it might be a stroke, but this patient is taking clopidogrel, it's not really a stroke. While in patient not taking clopidogrel, every single whitish spot, yeah, that's an ischemic lesion. It's not bad. It's just trying to show that the clopidogrel works. If he knows, if he's not blinded, he tends to see stroke in the group where he thinks they are not getting the right care. That's how the human brain works. It's not because he's a radiologist. It's just because that's human life. And sonography for, still radiology, sonography for ultrasound or lab test, the machine spit out the results, so it's more objective than interpretation of a test. But if you were to do a clinical assessment, you might be biased toward one direction, not, or say that you know that the patient is on DVT prophylaxis, he comes in with a swollen leg, but you know, is still the swollen, the swelling that follows the surgery. If he's not on prophy because he has low hemoglobin, or you send it immediately for ultrasound. That biases the study. So randomization, balance confounding. Blinding and concealment are to control bias, the systematic deviation in the observation that follows knowing what happened. So in this case, it says no one withdrew. This is a very fast study. Randomization, boom, medication immediately. The patient had no time of dying in between. Between the randomization and getting the pill, nothing could happen. So every patient was in the proper group. Does it make sense? Are we speaking a language that makes sense to you? Have you discussed randomized study this way before? Yes. You have some or not? He did. You didn't. This is the first time in your medical training you get exposed to EBM, unless you did it on your own. You don't have EBM or clinical epidemiology or stats? You have it at some point. Year 1 maybe.
Year 4 maybe.
Year 4, okay, so you're fresh of that. Good. So I'm going the right direction? Yes. And this is table 1, so we looked at table 1 already. Good. Now, this slide set put for the answer to this question blinding. Blinding is not really linked to retaining the same prognosis. It can help, of course, because if you don't know which treatment you are on, you do not tend to prescribe other treatments, but mostly is that there were no other differences. And of course, the most common deviation in the risk, why you want the two groups to be balanced for prognosis in the beginning? What's the reason? Yes, but confounding means if one risk is low, if one group is low risk and one group is high risk, the difference you see is not due to treatment, it's just due to risk, right?
As severity of...
Yeah, so if you have the control group is all high risk patient and they have a 40% rate of stroke, and the treated group has a 10% risk of stroke, 10%, you don't need treatment. Treatment group will do better anyways because their chance of having a stroke is 10%, while the control group is 40%. There's no comparison. They have to have the same baseline risk, right? To be at risk of an event, there is one basic characteristic. Of course, hypertension, smoking, Chinese race, these are all risk factors. But the most important risk factor is to be alive and to be in the study. You cannot have a stroke if you are not followed up. I mean, of course you can have a stroke, you can even be dead, but you will not count it as a stroke in the trial if you are not anymore included. So the most common deviation from balance in prognostic factor during the study is not being anymore in the study. Exclusion from the study. Exclusion, withdrawal, loss to follow-up. So what you check, as he was saying before, is at the end of the study, how many patients are left in the two arms, counting the events. So say you start with 100 and 100, and then you have 30 events and 20 events. Here you should have 70 patients without events, and here you should have 80 patients without events. If you then miss 10 here or here, those 10 unbalance the two groups. If you can't account for everyone, you have a problem. If I have 100, 70 alive, 30 stroke, 100, 80 alive, 20 stroke, this group is doing better. But if here you have 70 alive, 10 lost, 20 stroke, you may say, okay, here I have less stroke, 20 instead of 30, but I have lost 10. I don't know what happened to those 10. They might all be on the beach enjoying, or they might all be dead. I just don't know. So the two groups are not anymore balanced. Here I have 70 patients who could have a stroke and didn't, and here I have 10 patients that I don't know, so I'm still 70. I have 80 non-stroke, 10 I don't know anything about, so the one I know are okay, are 70 and 70. Okay? So the balance is there if I don't have lost at follow-up. Lost at follow-up, please.
With the p-value, right? If we analyze it, it will affect the p-value.
It should affect the p-value. It also affect the way you do the analysis, because, and this is one of the mistakes that was introduced with evidence-based medicine. They say the good study has to be analyzed by intention to treat, which means anyone who was randomized has to be accounted for. The bad use of intention to treat is I count them in the denominator, but I don't count everyone in the numerator. I have everyone in the group where they went, but then I only count those with event. Those that I miss, I don't count. That's not intention to treat. Intention to treat is counting everyone in the denominator and in the numerator. And then you have a problem there. How do I count the one I missed? I don't know if they had a stroke or not. Well,
I'll decrease the size of some.
no, you really have to make hypotheses. You say, well, what if they all had a stroke? That's the worst case scenario. Would still be a difference there. Or what if they are all well? And you may even say, I have lost 10 in the treatment group and 5 in the control group. I consider the 5 in the control group that I lost all well, and the 10 in the treatment group all bad, which is impossible. Usually things happen at random, so some will have had a stroke and some not, and the same in the control group. But the most extreme hypothesis is saying all those I don't know anything about in the control group, I assume that they are doing well. All those I don't know anything about in the treatment group, I assume they are dead. If I still see a difference, my treatment is strong. If I don't see a difference anymore, maybe that having lost patient doesn't let me explore if the treatment works or not. Does it make sense? Now, the hypothesis all dead, all alive is extreme. What you usually do, you make a reasonable assumption. The overall rate of stroke in that population is 10%. I assume 10% of the lost in both groups had a stroke, and 90% not. But I add those back into the study, making some assumption. Of course, you are a clever person. The study I trust better is the one where there are no lost at follow-up. Everyone is accounted for. Of course, it's not easy. You know how many patients do not come back to clinic. And if they do not come back to clinic, very likely they would be lost in a trial. But the trial that I have no doubt about has no lost at follow-up, or very little. I will cover this in my lecture this afternoon, how many I accept, how many I don't accept. It depends on balancing. If I have a 3% event rate, 3% lost at follow-up is too much. But if I have a 30% event rate, 3% doesn't matter. So I accept losing a small proportion of those with events. If my event rate is 11%, I can accept losing 2-3%. It doesn't affect. If I have 11 against 22, 3% more or less, there's still a difference.
There is any golden number?
Close to what the event rate is. There is no golden number. But the reasoning is, if all those that I lost were events, would that change my balance? If I have 15 against 30, 3% doesn't make any difference. If I have 1.5 against 3% make a huge difference. That can change the direction of the result of the study. Does it make sense? No. No. So, well, good for you to tell, even if you tell me or you show me saying, oh, what the heck is he saying? If you have 10 patients and 10 patients, say that we are stroke prevention. I have two groups of 10 and 10, and I treat this group, I don't treat this one. Here I have 5 stroke, here I have no stroke. So 5 stroke here, where I don't treat, no stroke where I treat. The difference is 5. If I lose 1 patient per group, doesn't change, because I have 5 stroke, 0 stroke. I lose 1 patient here and 1 patient here, still is 4 more. So if I have a lot of events and I lose a small proportion of patients, the difference, I have a 5 patient difference. If I lose 1, still I have 4 patient difference. But if I have 5 events, if I have, say, 2 events and 0, and I lose 2 patients per group, well, here I might have lost 2 patients without stroke, still 2 stroke. In the other group, I might have lost the 2 patients with stroke, and if those were in, I would have 2 and 2, no difference. So if the number of patients I lost is of the same size of the event, so I lost 2 and I have 2 stroke. If the 2 that I have lost were 2 stroke, I would see no difference. If I had 5 stroke here and 1 lost patient, even if that was a stroke, would still be 5 against 1. So still this is better. So the way I decide when I lost too many is when the number of those lost approaches the number of events that I observe, the number of the events difference between the 2 groups. Okay? Better? Okay, good. Okay, what's next? When we have to stop? Is 10 to, I think in 10 minutes, right? Okay, which question are we left with? Well, I think that some we covered indirectly. Follow-up, this is covered. Right? This is what we were discussing now.
Follow-up complete.
Primary outcome.
How large was the treatment effect?
Primary, secondary, with this all cover. Oh, sorry. Yeah, this we covered already. Reason for exclusion, this is still which patients were included, which were not included. We have covered this before when we were speaking of the population characteristics, right? How large was the treatment effect? That's your question. So how can you express a treatment effect? All of these ways.
Risk reduction.
Yeah.
Need to harm.
So what are the results in this case?
Results in this case.
So this is the table we have to fill. Let's focus on the primary outcome. Is the first row in table 2. How many events in the intervention group?
Primary outcome.
Yeah.
11.7.
Yes. So what's the relative risk? So 8.2 against 11. The relative risk is 70. Right? I mean, here they did a time to event analysis, so it's an hazard ratio, but the concept is more or less the same. There's time included. Why is 70%? Because it goes from 12 to 8, so 1/3 less reduction to 70. What's the relative risk reduction? The relative risk reduction is how much is reduced compared to the initial risk.
The initial risk is from 11 to 8
It's 30. It's a reduction of 30%, right?
Yeah.
Because it goes from 12 to 8 is a 30% reduction. The relative risk is 70. The relative risk reduction is 30. What's the absolute risk reduction?
From 11 to 8.
Yeah, we have rounded to 12, more or less.
Yeah, it will be 3.
3. 4 after rounding. Okay, and what's the number needed to treat? The number needed to treat is 1 over the absolute risk reduction
1 over the absolute risk reduction.
multiplied by 100 usually.
Around 30?
Yeah, 25. 100 by 4 is 20. Yeah, 1 by 4 is 0.25 multiplied by 100 is 25. So what's the interpretation of the number needed to treat?
You need to treat this number of cases to prevent one outcome.
Okay, you need to treat 25 patients to prevent one outcome. Is the patient happy when you tell him the number needed to treat? Not really, because it means that if the patient is clever, means that 24 patients are taking the pill for no reason. Only one of them is getting benefit. So the clever patient asks you back, I'm not happy with your number needed to treat. Tell me if I'm the one. And that's risk stratification, that's clinical prediction guides, and prognostic analysis. Maybe.
This will affect the level of recommendation in the guidelines.
Yeah, it would. And I'm not saying that it's stupid for the doctor, saying, oh, I have a drug that has a number needed to treat of 80 and one that has 25, I select the one that has 25. That's fine. But in communicating to the patient, you want to know how much his own risk changes. For the patient, there is no, the patient has, what are the patient risk is 0 or 1. Either he has stroke or not. So no stroke, 0, has stroke, 1. You may say, oh, your risk of stroke is 10% per year, which means every year, 100 patients like you, 10 get a stroke and 90 not. But he continues to say, okay, I don't care about 100 patients. I want to know about myself. Will I have a stroke or not? Because for me, it's either 0 or 1. Okay, so that's where it gets complicated communicating to the patient. What the patient usually understands better is the absolute risk reduction of 4, saying, okay, if 100 patients take pill, 4 less stroke will happen. And one, if he's a gambler, he understands what that means. If he's not a gambler, you are in trouble. But that's basically the concept. Now, for the other events, you do the same. and you calculate all the numbers. So now we say we can take whatever we want, the relative risk reduction, the hazard, the absolute. How precise is this estimate? How can we be sure that it's 25 and not 23 and not 27? Confidence interval. So you look at the confidence interval. How large is the confidence interval around this risk reduction?
A stroke from 0.57 to 0.81.
0.57 to 0.81. What does it mean? What is a confidence interval?
It's the value where it might be, if it's not close to zero.
So yeah, that's the interval. But why 0.57 to whatever? The meaning is, if you were to do this study over and over again, you would get in 100 replicates of the study, 95 times the effect will fall within the confidence interval. It's just statistics. And if you are a positive person, you say, okay, what's more likely? You cannot really tell after one study. Ideally, your central estimate is the more likely, can be anywhere on that confidence interval, but is more likely around the 0.3, if we think of relative risk reduction. The most likely is 30%, and then it can be as low as 15, as high as 45. Most likely is around 30. Can it be outside the confidence interval?
Can it be outside?
So, can the truth be outside the confidence interval?
If it was big, it's 95.
5%. In 5% of the cases is out of the confidence interval. And this is something that almost no one considers. Even a study like this published on New England, it tells you 95% of the cases, if you redo this study, the result will be in this interval. 5% of the cases will be beyond this interval. So if you are unlucky, this one here is false, because the truth can be somewhere else. And that's why you always look for systematic review, because at least you don't base your decision on one study, but you have at least 4, 5, 7, 20, 100 studies who got different results that all together points to where the effect of the medication is. The reason you want more studies is that when you have 20, you can tell, okay, the confidence interval where those 20 fall, that's very likely to be true, because you are beyond 5 replicas, so it's unlikely that the truth is elsewhere.
Just to solidify the evidence.
Yeah, but when you have only one study, you may be unlucky, and that's false. But the confidence interval, of course, is around what that study observed. If the truth is in the 5, that if you are really unlucky, can still be false. Now, confidence interval is on what I think you told, depends on the sample size. What make a confidence interval narrow? Increase the sample size, not only increase the. If you have 2 studies of 1,000 patients, one observes 10 events and one observes 100 events, how you see the confidence interval going?
If the less number, bigger.
Okay, less number of events, larger confidence interval. So larger study, narrower confidence interval. More events, narrower confidence interval. Larger difference between the two groups, narrower confidence interval for the difference. So the larger is the study, the more event you observe, the more difference between the group, the narrower the confidence interval.
The better the certainty.
The better the certainty, sure. Because in how the confidence interval impact your certainty, you have to think always pessimistic, and you think if the difference is the minimum likely, what the difference will be? 0.01%. I don't like that. We say 4, number needed to treat 25. You can build a confidence interval around it. And it may go from, I don't know, 0.18 to 0.37. Okay, it's good. Or can go from 2 to 3,000. I don't want to treat 3,000. I would like to treat 2, and every other gets an effect, but I don't want to treat 3,000 to get one effect. So the confidence interval helps you because you make your reasoning at the two extremes, and you decide what if the lower was true, what if the highest was true. We have covered already this question, right, in the beginning. And we have covered the very last point in not being happy with one single study. Even the best ever, largest, with most event study still is one study. So until it's confirmed, you need to have some doubt. Now, it's good to be able to appraise a study, knowing what concealment is and blah, blah, blah. When I was recommending you to consider registering for the McMaster Plus database is because every study you receive in the field of treatment has been checked already against all these criteria. If it fits these criteria, is analyzed properly, is double-blind, is concealed, follow-up is not a problem in terms of there is no attrition, it makes into the database. If any of these criteria is failed, it doesn't make into the database, it doesn't get to your mailbox, no matter who was sponsoring the study. And if it's a study about diagnosis, has fulfilled the criteria for diagnosis. So it's one good way of keeping up to date, only receiving studies that already have been appraised on this. Then you have to decide if they apply to your own patient. But as to the basic appraisal, this kind of appraisal has been done already. Okay. Oh, we are 5 minutes late. Sorry, I didn't see that. Make it in the notes. It was late. Sorry for that. Thank you.
We'll come back here again, right?
I have no idea. I know that I go to another color, but I think that the yellow sits here forever. Yes. That's your room. Nice one.